So that brings us up to this next slide, which is, I call it's an integration flowchart. And I've labelled it the 3 factors that influences treatment. So when I did my study, I asked the participants, what is it that helps you work out? What do you treat? What are things influence your treatment the most? What are the things that, as a practitioner, you feel you have to do to get your patients right? Okay, what is it that influences that? There's 3 things. The first thing that they all said is what the patient expects, the patient wants. I've called that patient wants. Now those patient expectations are often linked to their symptoms and get immediately out of distress, right? You can't ignore that because that's what they come in with. But some patients realise that symptoms are just the effect of deeper issues. So they might want you to go deeper and find the deeper causes, okay? Deeper causes links you to what else is going on and the relationship between that and the tissues causing symptoms. No, so just because of those 2 possibilities, you come back to those 2 relationships again. The second thing is what the body actually tells you, and I've called that tissue needs. So what the body tells you, in other words, when you assess, the body will tell you clues, give you clues about what's actually in trouble in this particular person. Okay? But because you don't know that, you don't know what else is there, you can't assess just the tissues with symptoms. You have to actually assess everything to figure it out. Does that make sense? So theoretically and practically, you need to do a holistic assessment. That's the indication for it. How else are you going to know what else is happening other than the tissues causing pain if you don't? The third thing that influences a person's decision-making process is the background education and knowledge. Okay, so at college you learn about biomedical education, and you learn about regional assessments. That informs you and prepares you. So you learn anatomy, physiology, pathology, common conditions, signs and symptoms of those conditions. You learn how to take a history, you learn how to do your regional and medical investigations and management process. Yeah? And I think no matter who you talk to in most professions, they would all learn that to some degree or other, to different depths. Now, the interesting thing here is note that this doesn't tell us what is actually needed, it just gives you a list of possibilities. And this only gives you a list of known possibilities based on people's usual experience. Does that make sense? Got to be aware that there could be other things going on that you have never been taught about. Make sense? So, you can't technically base your treatment on what the textbooks tell you, and that's what the participants said in my study. They said, well, one guy said it really nicely. He said, textbooks say go left, hands say go right, so you go right. So in other words, what he's saying is that the tissues tell you which way to go. So how does your biomedical knowledge help? If you think about it, it doesn't help you find the problem, although it does teach you processes for finding the problem. But if you think that most of those processes are regional, in other words, looking at the part with symptoms, again, it's emphasising the symptom. But if you add in what else, if you learn processes for looking at the whole body, the whole person, all of a sudden, you are looking at everything else as well. You're starting to get better at finding things. How does it help? Well, once you've actually found what's really going on in the person through a good assessment, both holistically and regionally, it helps you to explain the relationships between what else is happening and the tissues causing symptoms. Does that make sense? So it doesn't tell you what's happening, but it helps you to explain the relationship. Okay? After you've assessed tissue needs, after they're found first. So either way, you've got holistic education requires looking at relationships. Now you can look at this chart a different way, not a different way, but another way. If a practitioner does not trust their ability to feel the body, if they don't trust their skills, what are they going to do? What have they got left? The patient needs, patient wants, and the background education. So if you can't feel or see or sense what's going on in the body, you have no choice but to go back to what the textbooks tell you, what the research and evidence tells you, and what the patient wants. So a lot of the time as practitioners, we're giving the patients what they want, not necessarily what they need. And you don't even know if it's working unless the patient says, I feel better. But that's not a good way to tell if you've made a change. Because you can do great treatments on patients and they come back feeling worse. How do you know they're getting better or worse? If they're getting actually worse, the body tissues will tell you that. If they're getting better, the tissues will be healthier. They'll be functioning. There's more vitality, more quality of movement, more symmetry. Does that make sense? More tissue health. And that tells you that things are clearing and there's just a few things still in the way. It's just the next level. So the only way to really tell is what the body tells you. So if you don't know what's going on, you fall back on the other two. You fall back to what the textbooks say, because that's your informed educational process. That's supposed to be relatively reliable, and at least if you don't know, you've got something that you can go off. Does that make sense? That's not better than nothing, yeah? But the practitioners who do trust the body more, and therefore assess more holistically, they tend to rely less on what the patient tells you and what the background education tells you, because they know what's actually going on. And their treatments are safer because they're not treating what they don't know. They understand how it works. Okay? You have to find it first before you can explain it anyway. There's many a time when I've got my students to do an assignment and they've found the problems but they don't know what it all means, and I get them to write up their clinic projects, clinic summaries deliberately to make them look at the whole picture. And when I look at it, I go straight to the working diagnosis. And the working diagnosis is supposed to be a summary of the whole person, a summary of the relationship between what else they've found and the actual tissues. If I can't see the whole person in that working diagnosis, I then go to their assessments and I look at what they observed, what they felt, what they found on motion testing and their special testing, and usually they haven't even done those bits. So I find straight away, by looking at the diagnosis, I find out straight away where their weak spots are in their assessment, and I say next time the patient comes in, observe a little more, observe generally a little more. I've noticed you've got the local details really good, and you're finding the tissues causing pain, but you're missing everything else. So have a look at that next time, see if you find more information. And by the end of the semester, it'd take all semester, they'd come back with this report that had a beautiful explanation of relationships, and only about, not all the students got it, but a lot of them did. And they'd actually be able to explain the relationship between what their findings were and the symptom, and their treatment plan was based on what was actually going on and how to manage that and how to teach the people to manage it. They'd have a much better, more overall balanced picture, and they get better results than their clients. But the practitioners in my study, there's only 8 participants, but 5 of them said they always treat the symptoms, if for nothing more than to the patient to feel like they get what they wanted, just to meet their expectations. The 3 of them said, I very rarely treat the symptoms because it's really where the real dysfunction is, really where the main problem is. They only treat them if it's indicated. And they were the ones that had the biggest, broadest concept of holism and integrated in their practice the most, which was interesting. So that brings us on to, well, how do we recognise what else is going on? Now this is interesting because in my study I said to the participants, I said, okay, despite what the textbooks say and everything, once you've assessed the client, how do you know what to treat? What is it that tells you what you're going to treat? And most of them actually just stood there for a while and stared and went, they weren't sure. Some of them started going back, well, the textbooks told me, and I said, hang on. I said, I had to actually reword the question several times. I said, oh, hang on, that's what the textbooks say, but how do you know, out of everything the textbooks say, how do you know what you're going to treat or not? And then still I couldn't get many answers from some. So I went, okay, I'll make it easier. Let's say you assess someone and you find problem in 3 or 4 places, here, and here. What is it that tells you, makes you decide which one to treat first? How do you know which one to treat? Does that make sense? Mm-hmm. And they stopped and they thought about it and went, oh, actually I'm not sure. And they thought about it because I thought, this is really the important question, isn't it? It's like, how do you know out of everything you find which ones to treat and which ones to leave alone?
Some of them, 4 of them said, oh, it's intuition, it's an intuitive sense.
I was going to say, because it's a tough question.
Yeah.
Sometimes when
It threw them out because
Yeah.
they immediately wanted to go back to what they were taught,
Yeah.
and then,
Yeah.
but that didn't answer the question.
Yeah.
And I thought, well, intuition's not going to cut it in a scientific format. So I said, well, explain.
Yes.
What does that mean? And they ended up saying 2 things. Well, the feeling, the texture, the feeling of the tissues is really important. And the other word they used a lot was dysfunction. So they were seeing and feeling dysfunction and altered texture in the tissues. And all of them without any doubt, all said the same thing. One of those 2 things. None of them said pain. None of them said symptoms. Which was interesting because even though they told me earlier that a lot of them treat symptoms, when it came to the crunch about what they actually treated, it was based on the feeling and texture. And furthermore, they all said we treat other areas other than the symptoms or we would not get good results. That was their words. They nearly all said it. So that means that even though they don't necessarily, all of them don't understand how it all interrelates, none of them just treat symptoms, they all treat other areas. And that's why I asked them, how do you know what else to treat? And that's what they came up with. So, but the interesting wording was, I treat other things or I would not get good results. Which is almost implies that people know that the symptoms aren't all you should be treating on a subconscious level. This is just bringing it to the consciousness. So it comes down to 3 things, which is all in the osteo original philosophy and principles. It's ART, asymmetry, range or quality of motion abnormality, and tissue texture change. All 3 of those things are needed to have a treatable dysfunction. Okay? So, I use the example, Veronica, can I use an example? Can I get you to stand up? So this is setting the stage for the whole day. This is sort of scientifically setting the stage for the day. If you stand next to me here, if I take Veronica for example, she's standing fairly symmetrical overall, right? Mm-hmm. If I push her over to her right side, she's straight away off balance. Mm-hmm. Now, is she symmetrical? No, she's asymmetrical, so she has A. Yep. The tissues, what are the tissues going to do to help support her posture there? They're going to
change texture.
The texture's going to tighten up. Is she functioning? I won't hold her there too long.
I was going to say. Well,
if she's not falling over, she's functioning.
She's still functioning, yeah. Yes.
So she's got asymmetry, the tissues are tight, but the tissues are doing their job. Yes. And notice she was wobbling a little bit and struggling. So her tissues were struggling to do their job. The stability was off, right? She's got 2 of the 3. But technically, without the dysfunctional element, they're not treated. If you try and massage those tight muscles, which a lot of massage therapists will do, those traps are really tight. Let's massage them. You're actually ignoring the body's clues to say, we are healthy and tight, thank you very much. Yeah. I'm doing my job, I'm healthy, right? If you take me out, if you make me relax, this patient's going to fall over. That's like the analogy of, 2 men in a sailboat. One of them obliviously looks over the side and the boat starts to collapse, to capsize. The other person who's really on the ball thinks he immediately leans over the other side and counterbalances the weight. He's asymmetrical, he's tight, he's holding on, he's doing his job as long as he can. If you treated him, the whole boat would fall over. So that shows immediately how silly it is just to treat whatever's the immediate problem. Now, if I held Veronica over there for 8 hours, who's going to get tired first, her or me? Who's the cause of the problem?
You are.
Me. So I'm the problem, I'm pushing her over. After however long, the body's going to break down and manifest symptoms. Those muscles are now fatigued, the muscles may start to strain, they're going to start causing pain. If she goes along to the massage therapist and gets massaged now, there's a dysfunction, right? Okay, but she'll come out of the massage feeling great, and I'm pushing her over again, they're going to just get fatigued. So it comes back. So technically, what you're actually treating is an effect, not a cause. As soon as you correct my relationship with her, that's where the real problem is. Rebalance that, she stands up straight, weight comes off the shoulder and the arms and the back, and all of a sudden her tissues can relax. But obviously if she's been stuck like that for a long time, the body might not be used to that, so things might start to become dysfunctional somewhere else. That means that's when the body wants you to treat it. So technically the body tells us what to treat and when to treat it, if we listen. The health will tell us where to start, the problem tells us where to work. And it's like health is like water coming through a pipe. The blockage in the pipe is where the problem is, and where the water pressure builds up, it's vitality, the body's trying to break through. It's like that analogy I said before with the fire engine getting stuck at a roadblock. Fire engine gets to the roadblock. Fire engine represents health, the roadblock represents the problem. Health is getting stuck, getting through the problem. You can't get to the ankle, so you treat where it's stuck, open up the path, and suddenly it's free to move back down to where it gets stuck next. It might go to the knee next, and it might go to the ankle. As soon as you get that connection between the areas, the body's in sync. You know it's going to do its job and heal. But we as practitioners go, I have to do the healing. It's not us, it's the patient that does the healing. We're just making the client aware of interferences and helping to rebalance. We're like counsellors for the tissues. Thanks, you can sit down. So does that make sense? So, because a lot of practitioners just treat because of position, like it's rotated, so we rotate it the other way. They don't ask the question, is it actually functioning? That's a different question. You really need both. You need to have, that's why when you look at a posture, you start looking at them, and then you feel, and then you add movement in. And you're looking and feeling and observing for A, R and T. And that's there in the textbooks. It's funny, I found this article in the research by an osteo in 1960s. And it wasn't an actual study, it was just an opinion piece. But he said osteos unwittingly have methods in their training to assess the whole person. And I agree with him. I think that's my observation as well. The principles and the philosophy's there, but how many, if you asked how many practitioners actually understand and practice that philosophy, I think that would be interesting to see. I don't think it's as many as we think. All the good practitioners do. Now, once you've found that ART, what does it actually mean? We're looking at what else. Once we've got it, we can relate that primary area of ART. So we're not looking at symptoms anymore, we're looking at what else is going on in the body, interfering. That area or areas most interfering with recovery. What that represents is the physical manifestation of all involved relationship imbalances within a person's whole life. For example, the what else. Setting up, causing or contributing to the tissues causing symptoms or otherwise slowing recovery by interfering with the body's natural self-healing mechanisms. So happy with that definition? Now, we haven't linked this to the mental or emotional state yet. We've just found a physical location in the body for the area that's struggling the most. So if we use that ankle injury example again, we might find that the tissues causing pain is the ligaments in the ankle. And the ankle's a bit asymmetrical, and it's rolled out, and the ankle's rolled in and the leg's rolled out, and it's a bit out of position, but otherwise texturally feels okay. Then we look at the rest of the posture, we might notice that the pelvis it's rotated to the right, it's tilted to the left, it's jamming up in the right sacroiliac and the low back, and that area is all stuck. Okay, so mechanically, we assess and we think, well, this other area in the body is having an impact on the position of the leg and then affecting recovery from the ankle. You can relate it. Once you see it, you can start explaining the relationship just by looking and observing and describing what you see. Okay, but we haven't done anything to link it with the emotional, the mental, or any other state. It tells you physically where it's in trouble. The next step of that would be able to tune in to those tissues and ask questions. How's this linked to the person's emotional and organs and other systems? So you can take your assessment deeper and start looking at the relationships between that part of the body and other things. It could be as simple as saying, well, the patient did mention they're having some stress at work, okay, and low back often's got a lot to do with stability and taking burdens and pressure. So if you start studying a little bit about it, you start learning about the psychological links. And you could be working on the low back and you can think, well, physically it feels like this, I wonder what would happen to the tissues when I think about the person's emotional or work situation. And think about it, and all of a sudden everything gets tighter. It's like the body says, this is actually part of my problem, so therefore when you think about it, it makes it more amplified. If it had no effect on the problem, it tells you it's not no effect. It's like kinesiology. But the body literally does that. I've seen that in students. They could be massaging a hamstring, right? And you look at the person and you think, there's a lot of problem and pulling and restriction in the low back. And they're not even aware of it. And you get them massaging the hamstring, but thinking about the low back and the nerve levels while they're massaging the hamstring. And when they do that, they notice it resists them more. Suddenly, all of a sudden, it gets harder to massage. And they think, that's weird. What have they changed? They've only changed their link, their awareness to something else. And by doing that, suddenly it changes more. It's actually that easy, but it sounds a bit unbelievable, but it actually works. I've seen it happen over and over and over. As soon as you add the right spots in, even on the area you're working, it's linking things up. And what are you doing to the nervous system? You're giving feedback to the nervous system and the awareness and consciousness of the body, so they can become aware of what they need to do to heal themselves. So sometimes even describing what you see to clients is helpful, because they start going, oh, I can feel that. Oh yeah, that's doing that. And they start then trusting you to treat other areas, instead of going, what are you treating my back for when my neck's in trouble? A lot of the time we find it before we can explain it. Secondary problems, adaptive problems. That was I gave the example with Veronica. Secondary problems in the body, so we just talked about primary problems, the areas that are really dysfunctional. Secondary problems often compensate or adapt for primary problems. So, for example, that pelvic low back problem will place stress on symptomatic tissues, such as the ankle, and then cause pain. So technically a component may be asymmetrical or even have altered texture and even be symptomatic, but actually technically might not be dysfunctional. In other words, its relationship with surrounding anatomy is actually okay. That ligament is under stress. It's pulled, it's tight, it's sore, but it actually is functioning because it's not broken yet, or it's not torn. If it is torn, you suddenly go into acute injury management, where you have to do your first aid and all that sort of stuff. That means it's just gone beyond its natural limits, and it's been fatigued that much that it can't bear the load anymore, and it cracks. Does that make sense? And either way, what else is causing that stress in the first place? If you can change weight bearing, even if a millimetre or two, you take stress off the ligament, it can naturally heal. Just by rebalancing the pelvis, for example. And do you need any more examples, or is that clear? I've sort of been giving examples as I go. So, how do we know then what's really worth treating and what isn't? Whether it's regional or general, well, what else is indicated by ART in the whole body? In the area where the symptoms are, it's the same process. If you are going to treat something in the area where the symptoms, it'll have all three of ART still. In other words, if that calf and shin muscles are all hypertonic, and that's because when you sprain your ankle, you're stretching the muscle spindles, and they can reflexly contract to protect you against injury and get a bit spastic. Okay, but that might, after the injury, the muscles might still be shortened and stuck. And when you assess them, they're tight, they feel tight, they look asymmetrical, and when you stretch them, they feel limited or restricted. Right? You've got ART, so you could do some local massage and gliding of the tib fib and try and rebalance the positioning of the ankle to take stress off the ligaments. So whether you're talking locally or globally, ART works still. Yeah? Now in osteopathy nowadays, they teach not ART, they teach TART. I've asked students about it. What's T? The first T is tenderness, and then ART. Why would they do that, do you reckon? Is there a need for the tenderness? What does tenderness tell you? It's what the patient feels. First thing is, ART is what we feel as practitioners. It's got nothing to do with what the patient responds. Right? T is tenderness. Tenderness is only a clue to the tissue relationship between tissues and pain. It has an application to the area causing the pain. It does not relate to the whole what else at all. But nowadays, because of the emphasis on pain, patient symptoms, and modern emphasis on pain pathways and all that, people have added a T, which actually, if you go from art to tart, it sounds like you're prostituting the original philosophy. It's not the art of osteopathy or art of healing, it's now become prostituted. Now, in my research, I sort of just argued that, well, ART is your clue to find what else. TART is only helpful if you're looking in the reductionist biomedical framework, if you're looking at a regional to try and explain the relationship between tissues and symptoms. So when you're trying to reproduce symptoms, you end up going on what the patient tells you, not on what you feel. That's the first issue. And that's fine, it's good to get patient feedback, but again, that distracts us from trusting what we feel. So when my students used to say, oh, it was painful and tender, I'd say, great, that's what the patient felt, what did you feel? And they'd go, I better go back and double check again. Because every single time they went, oh, what did I feel? And yet when they write a treatment plan, when they write their diagnosis, they don't know what to write. When they write their findings, they don't know what to write. When they write the treatment plan, it's like massage the QLs, I massage psoas, I articulated, blah, blah, blah. And I go, that's interesting. You must have felt them to be able to see if they were in trouble. Were they hypertonic? Were they shortened? Were they actually, they'd say that they'd treat a weakness. I said, did you do the test of strength? No. How did you know they were weak? Oh, they looked weak. Oh.
It told me they were weak.
Yeah. But did you test? No. So in other words, people are just treating, they write down stuff in their treatment to make it look right. But in actual fact, if that's what is in their treatment, that should be in their assessment. You know, it makes sense? And then how do they know if that QL is short and tight or stretched and tight? Sometimes the opposite one feels tighter because it's stretched, but actually it feels healthy and it's functioning. It's just stretched. It's the side that's short and hiding away. That's when you, if the quadratus lumborum muscle was tight, technically if you side bend the opposite way, it should be resisting you. So your range of motion test will show altered quality of movement. But if you have a tight, short muscle and you stretch it and it doesn't actually limit the movement, that's not a muscular problem. Because the muscles are doing their job, they're not limited. But they're stretched or shortened for some other reason. So in other words, the interesting thing is, as practitioners, do we really listen to the body, or do we just go ahead and treat without really thinking it through? And I actually, in my students, in massage students, it took me all semester to get them to actually pay attention to what the body's telling them. They'd all treat according to what they were told to treat, and they'd just do a relaxation massage, and that half of them were probably feeling things but not recognising they were feeling them. Like massage therapists work their way through the body, and it's like they treat the tighter bits and the dysfunctional bits without realising it. They don't do everything equally unless they're doing a general relaxation, oblivious massage. So it's interesting. So then, if we go back to this diagram of concept and practice, concept's a block on the left, practice is a block on the right, we've now built a bridge between the two. The secret to connecting the two is ART. And I think that'll help. That just brings the ancient aspect of philosophy to the surface instead of it being ignored, which is what often happens. So, identifies what else is present, manifesting relationship imbalances between involved components of the whole person, and treatment involves a mindfulness of these relationships between what else and the tissues causing symptoms while the treatment is being implemented. Why is it important to watch that relationship during treatment? In other words, put it a different way, a lot of treatment is like, I think it is a sacroiliac joint causing pain. So the reductionist model would be, my working diagnosis is sacroiliac joint problem. But that's just a statement of a dysfunction. Which is, well, let's say, I'll use this way, let's say it's got a shoulder problem. Let's say I think that the shoulder pain is caused by impingement or rotator cuff problem, right? That's my symptomatic diagnosis. So a lot of practitioners will say, that's what I'm going to say I'm going to treat, and then they'll base that as their treatment plan for several treatments. And if that doesn't work, they'll come up with something new. That's got nothing to do with what I'm talking about in terms of finding the problem. So what's more informative? a rotator cuff impingement, or I've got a restriction in the right sacroiliac joint, okay, tilting my pelvis, shifting my pelvis to the right, my trunk to the left, my trunk side bends right with a hypertonic QL, rotating me to the right, forcing my scapula to go up and lateral, and that together with overhead work is impinging the rotator cuff. So it's a bit more lengthy, but it describes what's happening in my whole body, setting that rotator cuff up. That actually forms the basis of your treatment plan, because you say, all right, if there's a primary problem in the right sacroiliac QL, pulling the shoulder down and the pelvis up, if I release that, it's going to drop, the trunk's going to rebalance and come back to the middle, the scapula's going to roll back around the chest wall, and suddenly I'm in a better position for abducting my arm without impinging. And all without touching the shoulder. Now it makes sense, doesn't it? And so working diagnosis is your relationship, explanation of relationship between what else and the symptoms. Your differential diagnosis is just a list of possibilities what can be causing the pain. But a lot of practitioners make that their working diagnosis, and actually doesn't tell you what to treat. So if ever I saw that, if I just saw that without a link, I'd tell them to go find the link. Okay, and the reason you've got to be mindful of that relationship, because if you know that relationship was imbalanced, how do you know you've made a change? When you recheck that relationship, it's balanced again. Because you've resolved the conflict issue, and that's back to unity and harmony. And so if that's better, you don't have to rely on what the patient tells you to tell you they're better. You say, well, that relationship's improved. If you're still getting pain, must be a different one. So you might have the same symptomatic diagnosis every week, but the patterns in the body will be changing every week. You should never have to treat the same thing exactly the same way twice if we're treating properly.